Good evening and welcome to this meeting of the Adult Social Care and Health Select Committee. I am Councillor Lucy Knight, Chair of the committee, and I will be chairing tonight's meeting. The event is being live streamed on YouTube, and members of the public and the media are welcome to watch the meeting remotely and listen to discussions taking place. Now, I would like to welcome all those in Committee Room 1, Kensington Town Hall, and everyone watching on YouTube. Before we proceed the meeting, I would ask members of the committee to please make sure your mobile phones are off or on silent. I think it would be appropriate for us to start with 72 seconds silent to remember those who lost their lives in the Grenfell tragedy. And we're going to start with Agenda 1, membership and chair, vice chair. Note the membership of the committee and the chair, vice chair for the 2023-24 municipal year as agreed at the council meeting on the 24th of May 2023. Apologies for absence. Apologies of absence have been received from Councillor Stuart Graham and Councillor Portia Baxter. Declarations of interest. Does any member have an interest? Minutes of the meetings held on the 2nd of May 2023 and 24th of May 2023. The minutes of the previous meetings have been circulated. Does the committee agree to sign them as correct record?
I have no difficulty with the content, just on the meeting of the 24th of May, I was present at that in the council chamber.
Moving on to agenda item 5, childhood immunisations. That report provides an overview of the immunisation programmes in the Royal Borough of Kensington and Chelsea in 2022-2023. We're joined by colleagues from the NHS England, the Integrated Care System and Public Health. Can I ask everyone to introduce themselves to the Select Committee? Our guests tonight are Anna Raleigh, Director of Public Health, Kevin Driscoll, Integrated Care System, Lucy Rambello, Integrated Care System, Simon Hall and Andrew Rising, who are both GPs. Very much. Can I ask Anna Raleigh to introduce the report, and then for Kevin and Lucy to make an opening comment on important issues.
Yes, Chair, thank you very much. First of all, I'd like to start with apologies from our colleague Susan Eldon from NHS England, who cannot be with us this evening due to unforeseen circumstances. The paper that you've received was drafted and submitted by our NHSE colleagues. What we will do is we will talk a little bit about their kind of role and responsibility, but we also have together the partners around the table. So what colleagues will know is that immunisations is quite a complex delivery system, and that creates its own particular challenges. So NHS England, for example, is the commissioner of the immunisations programmes, and they commission immunisations from our primary care colleagues who are here with us this evening. They also commission the schools-based immunisation service from our provider, CNWL, which colleagues are here this evening as well. We are joined on the call by Kevin Driscoll, and Kevin Driscoll is the lead for the North West London IBC immunisations team. So there is also a team within the North West London NHS system that coordinates the response to flu, to TB. I'm sure Kevin will want to talk a little bit about the rollout of the MMR and the polio programme that will shortly be delivered within our patch. So alongside that, primary care are responsible for vaccinations for those with 0 to 5, so delivering those vaccination programmes. And we within public health have an oversight function. So the role for public health is basically looking across this fragmented system, this complex delivery system, and looking to kind of galvanise the system to identify challenges within the system and to sort of bring the system together to respond to those challenges. You will have seen from the paper that there have been some improvements in vaccination uptake within Kensington and Chelsea in recent times, and we're really pleased about that. However, childhood immunisation coverage within the borough does remain amongst the 25% lowest within England. And whilst average uptake has fallen in England and across London overall, uptake in Kensington and Chelsea has held fairly steady and improved for most immunisations in 21-22 compared to those previous years. For example, coverage of MMR2 at 5 years has increased from 66 in 2021 to 72 in 21-22. And we now perform better than other London boroughs, and we no longer have the lowest uptake nationally. In 2021, uptake was the 4th lowest in England, and in 21-22, our uptake is now table. So we've still got an awful lot to do to improve, but much of the work that has taken place recently, and I believe it is no one thing, it is a combination of factors that will have contributed to this improvement. And that's something that we're analysing very closely as a system to understand further. And I think colleagues around the table will want to talk about some of the initiatives that they've put in place and some of the steps that are contributing to that. We know we've got significant numbers of children within Kensington and Chelsea who remain unvaccinated. And also significant numbers who are missing one vaccination. So there is a challenge for us as a system to address that as we move forward, particularly in light of the current London measles outbreak, which to date we haven't seen a significant number of cases locally, but our surrounding North West London boroughs have. And it's really important that we're working as a system to consider how we prevent an outbreak within our borough and protect our children and young people. So that's all I have to say as a part of introduction, other than to add we are a very complex borough, Kensington and Chelsea. We have very affluent communities living alongside very disadvantaged communities. There is no real geographical sort of message around that, or necessarily in relation to uptake amongst our disadvantaged or more affluent communities. The uptake varies within the borough from 55% in Earls Court to 83% in South Kensington. So that in itself creates particular challenges for us. We've got a lot of children following foreign immunisation schedules, and that too creates challenges for us, and also for our GP systems in kind of collecting that data and reporting and recording that data to get a really clear picture of what our uptake is. So if I now hand over to our colleagues from the local systems and primary care. Andrew, would you like to?
Is it Kevin that's going to? Is it Kevin you want to speak to next?
I think it's.
Yeah, can do, Andrew. I mean, we can just talk briefly about what we're doing in terms of the borough-based plans that we've set up. Colleagues will know that we have had a number of measles cases confirmed across 5 boroughs in northwest London. Fortunately, we've had no confirmed cases so far in the Tri-Borough or in West London or RBKC. But nevertheless, obviously, we need to work with all of our boroughs in terms of improving uptake. We've got a plan which is very much focused on supporting with MMR and polio in terms of a catch-up. And we know the areas in terms of those GP practices that need additional support. So as part of the plan, what we've done is we've fleshed out the data in terms of those practices that have some distance to go in terms of their population. We've provided that back to our RBKC colleagues and our health colleagues in West London. We've got a plan which is fleshed out with 3 specific areas, which are focusing on schools-based delivery. So our SACE providers are running call centres and calling parents of children that remain unvaccinated or partially vaccinated. And they're doing this in geographical areas. They are obviously focusing on those areas with low uptake. And they're making contact with those parents, and where there's a need, they are also going into those schools to run schools-based clinics, with a very specific focus on MMR and polio in the first instance. What they are doing is sharing lists of schools they will be visiting, and we will share those lists as we go through the campaign with our borough-based colleagues. We obviously don't want to duplicate effort, so that's the reason for working very closely with our SACE providers in terms of the work they are doing and understanding which geographical areas they are focusing on. The other key bit of the plan is the enhanced primary care call and recall. So Andrew and other colleagues will be very aware of the call and recall process, which is a specific approach in primary care to make contact with parents who have children who are unvaccinated or partially vaccinated and are becoming eligible for the scheduled vaccinations. As I say, as part of this plan, what we've done is identified those practices that have children who, from our records and from the data, look to be unvaccinated, and then we are working with those primary care colleagues to ensure that contact is made and that they are following the call and recall process, which is generally at least 3 contacts should be made with those parents, or attempted contacts in the first instance. There are a set of standards around call and recall. We have a immunisation coordinator who works as part of our team, and Shanna Patel, who's your immunisation coordinator, is working very closely with practices to make sure that those practices are following the relevant standards as set out in the GP contract, and also set out in terms of the best practice in terms of following call and recall. Shanna also uses a set of key lines of inquiries, so that's following a whole range of issues in terms of understanding where GPs are in terms of call and recall, but some of the other issues around coding, making sure that they are coding appropriately and correctly when vaccinations are taking place. And it's fair to say that we have had coding issues and still have coding issues in terms of vaccinations. Very important, obviously, to get a full understanding and overview of what is actually taking place. So the team are also doing some work around making sure there's some data cleansing going on, and, as I say, making sure that GPs are using the correct codes when these vaccinations take place, and the IMS coordinators are supporting with that work, as well as the sort of hand-to-hand and one-to-one support. What we're also doing is a weekly set of communications, which is going out now through the GP bulletin, and that's reminding our GP colleagues of the necessity to undertake searches on their clinical systems, identifying those patients who are unvaccinated or partially vaccinated, and then making contact as outlined in terms of the call and recall process. We've also developed a telephone script for GPs to use, and that's based on best practice from what we know what works in terms of actually influencing behaviour. And behaviour is really key in this, because obviously some parents have some hesitancy around vaccine uptake. And we know from the Wakefield issues a few years ago, that's had a significant impact in terms of parents not necessarily wanting to come forward for the MMR vaccine. So influencing behaviour in terms of some of those discussions are absolutely important. And the other key thing that we're doing as part of that enhanced primary care work is ensuring that we're linking in with our community engagement teams. And we have two sets of teams. We obviously have community engagement teams that work as part of the local authority, but we also have community engagement teams that work as part of the ICB and the ICS. And what we're doing is making sure that we're using that resource appropriately in terms of identifying those community groups that are not coming forward, are potentially vaccine hesitant, or just cautious in terms of actually engaging with health services. And we know from a local authority point of view, those community engagement teams have very often built very trusting relationships with those local communities over a period of years. And we want to build on those trusted relationships to gain access to some of those communities who are not coming forward, and providing them with the right information to make the decisions in terms of coming forward for their child's vaccination. And the third element of the plan is really about outreach, because what we know from the data is that although we have the call and recall process in primary care, many parents do not respond to that process. Some parents, do not have their child registered, for instance, with a GP, or simply not coming forward to engage with local health services. And it's that population that we want to reach with the outreach model. And the outreach model is being delivered by our North West London roving team, which is a team of clinicians. It's a team of nurses supported by administrators who've got a lot of experience in terms of running a whole range of programs and campaigns. They've supported with phase 1 polio catch-up a few months ago. They've also run the COVID vaccination program and have experience of running clinics in a whole range of settings, including going into traveller communities, etc., to run clinics on site. So there's a huge amount of experience supporting that intervention, and that is starting to be rolled out over the next week or so. And what we're doing is using that resource across North West London, and there will be opportunity for the team to work in RBKC. But that resource will also work alongside the community engagement teams. Very important that they link in with the community engagement teams to ensure that they have facilitated access into those communities rather than just turning up and expecting people to engage with them. So that's a key and crucial part of that element of the plan. And also we're doing some bespoke targeted communications as well to support that element of the plan. So there are three elements, as I say: schools-based delivery, the enhanced primary care call and recall, and the outreach model that's being developed to support boroughs. And we understand from the data and from the information that we know about RBKC is there is vaccine hesitancy or low uptake in some in North Kensington, for instance, and some parts of the borough. around the North Kensington area. So that's what would be a focus of area of support for us over the coming days and weeks ahead. I will pause at that moment because I realise I've been talking for some time.
Thank you very much, Kevin. I think we should probably move to committee unless there's anything that.
Very happy to answer questions.
Thank you, thank you so much for providing us with this important report, particularly at a time where there is an increased risk from circulating vaccine preventable diseases in North West London. I wanted to start by going to page 23, which is the data provided to us, and it's quite concerning to look over. And firstly ask you why you think RBKC is the worst performing borough in North West London, including against Westminster and Hammersmith and Fulham, which also have in the London population profiles. And secondly, how are we fighting to remove barriers through communication? The challenges identified on page 25 include a lack of trust and confidence in vaccines, and a lack of awareness of immunisation. So what are we doing to combat this, and how are the NHS, Council and LCB working collaboratively to break down these barriers?
Should I start? So I've been a GP in Islington and Chelsea for the last 25 years, and I've had some role in leadership from PCD to CCGJs and now to ICB. So this has been at the top of the list issue for quite some time. Kensington, Chelsea and Westminster have historically had difficulty because of their populations. Some of the messages we heard around transient populations and a lot of people moving in with different regimes of vaccinations. So we've been trying to fix it in lots of different ways. I think what you maybe can't see from the table is that Kensington and Chelsea and Westminster have both been improving, whereas the boroughs maybe have been stable or going down. So we are on a process of improving. We have had the opportunity since the ICB started of working very closely with our neighbours in Borough, and they have started a series of initiatives which we are joining them in, which we think may have had impacts on how vaccine has been uptaken. Some of those include things like family hubs, care coordinators, work on coding, work on list cleansing as well. Now, all of these things have been happening in West RBKC as well, but we have maybe missed some of the integration and the focus that Westminster have had, and that's certainly something that we will be picking up and taking forward going forward. I think some of the improvement we've had over the last couple of years has been because we've had the ability to work together in a much more integrated manner, so working with public health and working with the local authority. And also, I think, on a lot of lessons that we learned from COVID and flu vaccinations in the last few years as well.
Just on what do boroughs that are better than us do that we don't do? And why don't we do what they do?
So I don't think there's anything that they do that we don't do. I think we have looked around. We have historically looked around North West London and London around what's happening and to see if there is a magic bullet. So I don't think there is anything. We have had lots of theories about why there are differences. We've got similar differences in some areas like cancer screening as well. So there is maybe something around how the message is heard from the NHS and public health and how it lands maybe in different communities and things too. But we have been trying very hard to work out what might be the thing to help. And what we are beginning to see, I think, in some of the work that Westminster are doing is that it's probably a combination of lots of small things that make a difference. And what we're learning from Westminster is how we can bring those together as a package to make a much bigger impact.
Thank you. I don't know a lot about this subject, but I have read what's in here. So I apologise if some of these things seem not sensible questions, but you can help me improve my knowledge. And I was very impressed by a lot of measures being discussed in here and by what we've heard in this meeting, because this is absolutely complex in terms of number of people involved, and also working out whether the data is misleading us. It's an unusual position to see our borough and with lots of people working on it with figures like this, and therefore I think maybe there are some sort of special factors rather than people just not taking enough care or whatever it is. There must be some special factors that are working here. So can I just take a little bit of time just to understand this? In terms of actual evidence of behind the data, is it recorded when you are making contact with parents and chasing up for vaccines? And is there any sort of, does anyone ever give a reason? Do they just say, I'm not interested, or I don't trust? And is there any sort of tracking or recording of reasons that people don't proceed with it?
So not in GP systems, no. We keep a record of the offer and whether they're accepted or declined, but we don't keep a record of why. I'm sure no.
Because we get that data from you.
Yeah.
Because that to me is the first thing. Is it because people are saying, I've got it all covered because we're also registered in France or actually in Germany, and therefore we'll come to you with certain things, but all will not going with my home country regime? We don't know that. Or is it because they're coming from sort of the country which says we don't believe in vaccines and exactly. If we don't have that information, I don't know whether anecdotally we've got.
We do have it anecdotally. So certainly when we have conversations with families, we hear things like we're following a different regime with our private paediatrician, or we're getting it when we go home if they're European, if they're from America or other parts of the world. We do have some conversations with people who aren't sold on the idea of vaccinations anyway. We still have a legacy, I think, from Dr. Wakefield's work around measles and autism, and that's something that's stayed in the culture a little bit, particularly amongst some groups. So that's a conversation we're having still. So sometimes it's around other things, just like the convenience of vaccines and of giving vaccines as well. So we've tried very hard to make sure that vaccines are available, immunisation is available at weekends or after school, if that makes it easier. So it's often, as I said, lots of small things that hopefully will make a difference.
And this may be something you can't really speculate on, but those anecdotal reasons do feel very valuable, and it's not a layer of data that could be captured. I don't know if there's some sort of holding or something across more of London that would say is Kensington and Chelsea have a particular issue with some of those, particularly maybe around people following other regimes in other countries. Also, a lot of people might be here and partially living in other countries as well. And if we could actually say that, that would help explain some of these charts. The other one, just on a very sort of overall basis, is if I look at it and say, well, I'm not sure whether I believe fully in vaccines, then what is the data if it's collected at all on illness rates from that could correlate with the low vaccination rate? I don't know if this is too complicated a question, but what I'm thinking is that it would be, it's not necessarily correlated that lower scores for Kensington and Chelsea would be correlated with a higher incidence of the disease being contracted. And that would be another way of testing the data, which is we're missing all those people who are vaccinated but are outside of our system. So if you look at the data for Kensington on page 23 and compare it with others, is there any evidence to say that the illness rates are following the vaccination rate?
So I think the measles outbreak is a very good example of that. So we've got measles is highest in, well, if you look at Hillingdon has a high percentage of vaccination in the general population. The travelling population itself has not been vaccinated, and it's those children that are coming down with the measles. So there is a good mapping you can do often against disease activity and low immunisation rates.
Yeah, but we do know Sorry.
So I was just going to come in to support Andrew's comment there, because Hillingdon is a borough which has really good performance around childhood immunisations, and particularly around MMR2. But the outbreak in Hillingdon, UXA, UK Health Security Agency, have done the analysis, obviously, and most of those cases are for children who are unvaccinated. So that kind of substantiates the need to have children vaccinated.
Yeah, thank you. And the conclusion from that, if you can draw one on serial data, is that a sort of convincing line, if one is having discussion with parents, potentially is to say we do have lower vaccination rates and we have higher illness rates, and therefore vaccination is effective, and then people choose to take that on board or not. Sorry, I've got a few more as otherwise. Those are the overall stacked ones. Looking at the data itself, which you mentioned, has been improving. The period for this, it's saying, is it October 22 to December 22? That's the 3-month period that this is.
So it's Q3 data that Susan was put into her report.
Mm-hmm. Yeah, and if we were looking at a 3 or 5 year trend, because sometimes taking 1 quarter in isolation might give us a shock, or might tell us that we're doing rather well. I'm guessing behind this you're looking at much longer trend data.
So absolutely. So the data I referred to at the beginning was annual data. So I talked about the 2021 and the 21-22 data. We're waiting to get the final cut of Q4 data through, and then shortly after that it will be amalgamated for the year, and then we'll have a further year's analysis. Q3 does tend to be interesting sometimes, because the flu vaccination programme can sometimes impact on Q3 performance. And of course, the annual picture, when all the data is cleaned, does give us the opportunity to look at those trends, and we'll be quite keen to do that as that data becomes available.
Do other parts of the national organisation look to London and say, you're nowhere near 95%, you're going to get there, or is there a general understanding that transient population, international population, not just actually higher deprivation, because there are some figures you mentioned, there are areas which are not necessarily related to higher deprivation rates. Is there a recognition of this nationally in London as a hard place to crack for this achieving 95%?
So Kevin would like to come in on that.
Yeah, I mean, the 95% World Health Organization ambition, no area in the country is meeting that 95%. Obviously, it's an ambition for all of us to get to, and obviously there's some work to be done in RBKC to get you to 95%. But no area in the country is achieving that, and London is always behind the rest of the country in terms of childhood immunisations because of the complexities of the populations within the capital. So, but yeah, 95% is an ambition, but nowhere is meeting that ambition currently.
Thank you. Some quick ones now. Bottom of page 28, an operational working group is in development. It may have been talked about, I may have missed it in some of the comments, but is that a sort of whole area, or RBKC operational working group?
That is an operational working group across the 5 borough. I think what we're really trying to do is learn lessons from each other. Mm-hmm. And I think, as Andrew referenced, particularly at the moment, maybe Westminster in a couple of areas have done things that we can learn from, and we will be bringing those lessons into RBKC, so that's across the.
And on page 29, about the way down, one of the sort of steps being taken is and I know it's hard, is clearing any ghost patients, and living in a house with 6 flats, and having done that for 25 years, the amount of mail that survives saying NHS as people who have drifted away from the area or moved completely. I just wonder whether the high rate of moving, rather than just necessarily deprivation, could be meaning that we're recording a lot of people as existing and not being immunised. And it's obviously not formidable methods it goes to patients. Is that thought to be applicable to these answers?
Yeah, it is. And I think it affects all our targets in Vibara. And so we have repeated efforts to try and get this as accurate as possible.
And there's a statistic. Exactly right. Is it about 30% of GP practice list turnover? And that is a real outlier compared with the rest of the country. So there's that constant churn, exactly as you described. I've lived in a flat with exactly the same thing going on. There are people moving on so quickly, GP lists don't get updated. I think that Central, West London, Westminster are doing some really good stuff. I certainly think that one of the things that would explain the differential between RBKC and Westminster is that they've done some real drilling down, some work around cleaning their lists, which I think we need to do as well in RBKC.
So we have an example where obviously people used to, until there was this change in plan, people used to stick around on the electoral register and they just were deemed to be there until someone said they were not there. It's quite different. So you stay forever on a GP list, do you? Or there's nothing which says you haven't appeared for 2 years or often. Right?
No, so there is a national program where if there's no activity, we're sent lists, and also practices are encouraged if they haven't seen any activity for 2 or 3 years to contact the patient to see if they're still
Okay, it's not as of removed if you don't contact. It's up to the practice.
No, because you can imagine you'd be drowned in letters from patients complaining that they've been chucked off their NHS GP list.
Yeah.
No.
Yeah, thank you. It's a really quick one, and it links to your first question, actually, just thinking about the factors that might prevent people from just taking up the vaccines. I think an important area is just the lack of trust that people have in the medical profession now, and specifically among certain groups, cultural and sort of ethnic backgrounds, who've historically experienced the medical system, the health system, being quite discriminatory against them, quite rightly. Just what's being done specifically to target those groups, just to help improve the trust.
Yes, so we have hyper local educational events to get there. What we are seeing, we have got some case coordinators in RBKC, which follow on from a tradition that's actually a Brazilian tradition of a type of case coordinators Westminster have had for a little bit longer than us. And these are kind of case coordinators that are very local. In fact, they may only be working in several blocks of housing, so get to know the families very well. And so they can go in and get to know the families and then give a message around the safety or the appropriateness of a vaccine. And what can make a big difference to your figures is because these are relatively small numbers, it might only take one family to take their kids along to the vaccine, that suddenly the percentage rates are quite high.
Are you like the community connectors?
Yes.
Okay. Is that something that's being trialled in this area?
Yeah, so we've got them at Coville and we've done in North Kensington, and we're hoping to spread them out to other PCNs as well.
And has that been effective, or is it too soon to?
So it's probably too soon to be absolutely sure, but I think anecdotally we're very sorry. But we are reasonably optimistic, aren't we?
Yeah, there's some evidence from the Westminster pilot that started a year before our pilot, that those families who have a community health and wellbeing worker have got higher uptake of immunisation, higher uptake of screening, particularly, and better engagement with services. So that's what we're hoping we'll see. So we're about 6-7 months in within our pilot here. So as well as in North Kensington, we also have them in Chelsea Riverside as well. But look forward to expanding the scheme and see evidence builds.
Sorry, I didn't come across that.
So we may not have mentioned it.
Danny, and then Jared.
And just coming off Maria's factors as well, there's from a Health Watch perspective, service delivery, right? There's a lot of people involved. There's the community engagement teams, the case coordinators. There's a euthanasia. There was another coordinator mentioned previously. If I'm trying to help alongside this, who do I talk, where do I start? Because there seems to be a lot of people involved. You know, this is a really high priority in terms of Health Watch perspective. What would our involvement look like to get rid of, you know, help get the messaging out there as a partnership?
So we have a immunisations board, and as a first point of call, I think it'd be really good to link you up with our immunisations board.
Yeah.
And to start some conversations around how we can work better together. So,
yeah, because we are based in the community and we've got a full service. But if I turned around to the lead project manager of Kensington Chelsea tomorrow and I'll say, there's a lot of professionals involved. There seems to be something slightly, and I'm figuring it's the lack of trust. That seems what it comes back to, is what we're seeing in terms of our base. We're based in different food banks, but we're more than happy to do campaign work around that. It's just knowing who to go to, you know, that would be.
I don't know if you also wanted to mention about the cultural competency training.
Yeah, I guess that this is something that one of the things that's come out of our work in the case of following Grenfell disaster is kind of understanding how much difference cultural differences make to how people hear messages and how we can share messages with them. So Krishna, who's been working with the recovery team, has created this cultural competency training, which is for care workers generally, and it's been accredited by the Royal College of GPs, and it just started in the last 2 or 3 months. It's really good if you get the opportunity to get it. You may not need it, of course, but you get the opportunity to go and do it. It's really good. So we're encouraging all GPs and other people involved in care to go along and get that, and hopefully that will address some of the reasons why people maybe don't hear what we think we're telling them.
I could just add a related subject. We have set up what we're calling our Vibrant and Healthy Communities programme, and this really is trying to reach more deeply into the communities that we're looking to work with, working with faith leaders and other really key people in these communities. I think at a much deeper level than perhaps we've done over the year. The voluntary sector partners that we work with, there's a community chest that we've developed, which is a budget which we're going to be making available for them to sort of go out there and work with local voluntary sector organisations to really try and get to the parts of the populations that perhaps we haven't really reached over the years. So I think that there definitely is a much more integrated way of working across partners and much more of a kind of bottom-up approach than we've historically taken. Real difference.
Thank you very much. First of all, something that I thought was naive, there was quite a simple thing in immunisation. Reading this paper has made it a completely complex thing. And Simon, just listening to what you said there, great stuff, but you mentioned about 4 or 5 different agencies in your answer there. I wonder if part of the problem is the number of agencies is so diverse that actually it's quite complicated, and maybe following on from your point. But just going back to the table, because I don't know what those immunisations are because they're medical codes and in a way it doesn't matter. What shocked me in a way was the discrepancy between some of the KNC ones and some of the Westminster ones. And I would have thought in terms of population, mixed populations, diverse populations, we're pretty similar. We might have more of one particular cultural bit than another, but that is some of those are 8 to 10%. So it's good news that we're doing the by-borough work, and should I be shocked at the difference between the 2 boroughs, bearing in mind our similarities?
We certainly should be challenged by them and looking for reasons for them. If you look at the graph for a longer period, you'll see that
it's only 3 months out.
Yeah, RBKC and Westminster often do cross each other over, and because the percentages are for any particular quarter are based on a relatively small population, the percentages can be affected by dramatically. However, that's not to be complacent. I think we genuinely can see something happening in Westminster that we may be slightly behind the trend here in RBKC. So I think there are some lessons for us to learn. But I don't think it's we're quite as far behind them as these figures might suggest.
Yeah, I mean, I think absolutely would expect that question, and I'd be asking the same question myself. Well, we have been in your shoes, I certainly would. But I think, as Andrew said, if you looked at another quarter, I looked at the data that was over a longer period, and a couple of quarters ago, it was the other way around, where actually RBKC were doing better than Westminster on quite a number of these. And I think that whatever it is that Westminster's doing, and we're talking obviously in detail with them, it's something that we can make happen quite fast. I mean, for example, we talked about the data and about the ghost data. Don't want to use that term, about list cleansing. I think they've done more of that than we've done. Something like that can make quite a big difference very quickly. So, you know, I don't think the gap is as big as this data shows. And as I'm saying, if you look over a period of time, we've been pretty much neck and neck. If anything, RBKC have slightly better rates. So I think if we were back in a year's time, I certainly wouldn't be 6 months time. I wouldn't be expecting these numbers to look.
Thank you. How often are these results produced every quarter?
Yeah.
Quarterly, yeah.
For the committee, it'd be great if we could continue, even though we can hear from colleagues what's going on in terms of outbreaks, just to keep an eye on it in case we want to
Can I just build on that? So I was going to suggest that if it is produced, which it is every quarter, the interesting thing without requiring a big paper would be for us to see on a quarterly basis the new quarter of data produced, the previous quarter, and maybe set against a 3-year average, just so we can see as things bounce around, because then we, as you've been saying, we might be less shocked or get more information on it. The second thing, which I think is statistically very valid, is if we're talking about 15 children, you know, in one borough in one quarter getting something, and then 10 the next, then just by seeing how small these numbers are, the percentages are actually shocking us unnecessarily, and maybe there's more to buy that. So if someone can make a statistically, someone can make a note saying it's based on an entire sample size of, you know, if it's 10, or if it's 100, or if it's 1,000, these percentage numbers could be misdirecting us. And not to make a big paper out of it, but if we just had something on one page and then a couple of headlines, just that would be something like
I'm sure that would be very easy. I mean, we are creating a GP dashboard around activity for immunisations and cancer screening as well. So maybe we share the dashboard.
And is it possible for novices like me to put what the vaccine is down the side rather than doctors? Unless you're designing it, unless you don't want us to know.
I was just going to ask, in terms of, I know we've been speaking about ghost patients, but in terms of foreigners who are coming into the country or refugees who don't have history of their vaccinations or can't remember, what are we doing in these situations? Hopefully the majority of them are registering, but how do you deal with a case where someone has no idea what they've had?
Yeah, so that's part of our work with, so when we had the Afghans coming in big groups, there was a big program around making sure that they were registered with the GPs, that we had a history, a family, general history, but children's immunisation history too, and where they weren't known was negative, that they got their vaccinations as quickly as possible.
And again, one last question if anyone else has anything before we go to Sarah. I was just going to ask how effective the response has been following the outbreak of measles and other virus.
Okay.
Well, it's still fairly early days. I mean, the outbreak, in Hillingdon occurred a few weeks ago. So the plan has been shared with colleagues within the last week. So we are pushing very hard to implement and to deliver. We expect to see impact over the coming weeks. I mean, the thing around data is if we can get the data cleansed, coding is correct, that will start to improve the data itself, which then in terms of the performance reports does have an impact. In terms of practice, operational practice, as I say, the team are going in and supporting practices around call and recall, and as I say, the other offer is around outreach, and that will take a little bit more to understand, whether that's having an impact. But we expect, those populations who are not coming forward, if we can get those vaccinated, we know that they're often the most at risk, and the Hillingdon example substantiates that, as I say, because most of the cases were for children who were unvaccinated. So that's going to be a priority for us. So I guess in RBKC, too soon to understand the impact, but obviously we'll update committee members and colleagues on how the plan is being delivered and the outcomes that have been achieved, and we'll do that on a regular basis. There are project and planning groups in RBKC, so that information can be shared more widely from that group.
Great, thank you very much, Kevin. And Sarah, you had a question.
Thank you, Chair. A couple of questions, and I think I know what the answers are going to be, but I'm still going to ask them. The first thing is, our children spend most of their time at school. It's great to hear there's going to be this road into the nurseries. I really do think there's more we could keep doing with school. I know I bring this up every time, advanced the system, you can't learn, you cannot start school without your vaccination. So I do think there's something more we can do. We can't assist, but I think we can ask. Also around children with learning disabilities, who's obviously very suspected straightforward. Eventually, if there's something more that can be done there. And then the other issues around private GPs. Is there any way that data could be made? Because we know 50% of the children are educated and lots of them go to a private GP. So I think that's an enormous opportunity.
Yeah. So yes.
Oh, I think it's no.
So certainly we have new codes for vaccines which do allow us to enter more data, both for foreign vaccination programs and from private GPs as well. So more of that immunisation activity is going into their GP notes, so that should make a difference.
And I think, if you're working with our children's services for schools, if they could share some data that will be registered. Have they handled their vaccination?
Okay.
Thank you very much for all coming. And I think in terms of what we just spoke about, it'd be really great if we could receive some updates on those, on the data for the RBKC vaccines against in the way that Sam described too. Would be wonderful. And then also what Danny said about Healthwatch and the board. It's a really good idea so that you guys can work closer together. And yeah, any updates on the hearing on anything would be much appreciated to the council, to the committee. Thank you very much.
Thank you.
Thanks. Moving on to agenda item 6, the update on the Borden Hospital. This report sets out an update to members on the Borden Hospital, in particular the feature of the NHS boards. Lead member of Adult Social Care and Health to release application. Thank you. And Sheridan Community Services Manager, CMWL, and Karen Jarvis, Medical Director, CMW, are present.
Thank you.
So to introduce myself, I'm Gareth Jarvis, I'm a consultant psychiatrist, and I'm the Medical Director of Jameson Division at CMWL. So we lead the adult mental health and learning disability services across Kensington, Chelsea, Westminster, Harrow and Brent. And my colleague.
Hi everyone, I'm Anne Sheridan, I'm the Managing Director for the Jameson Division working alongside Gareth.
And so I'll provide the initial update and then I'll make it necessary. And we obviously presented to this committee before about the Gordon temporary closure of beds and the process we're heading into, the consultation around those. Just to briefly recap on where we got to, the beds, the 51 beds for acute inpatients at the Gordon Hospital were temporarily closed during COVID due to infection control concerns and the need to bolster up the staffing in other parts of the system. To cope with that closure of the beds, we stepped up some new solutions for how you address people with mental health crisis. That included things such as the step-down beds to bring people out of old wards earlier and quicker with support into the community, with the crisis house, which is a less restrictive option for people when they're in a crisis. They can have their needs attended to and supported there without the restrictions that a Box ward has. And we also stepped up something called the Mental Health Crisis Assessment Service, which is an alternative to the emergency departments. So people are attending there. They've got a non-medicalising, quieter space away from the emergency department to help resolve their crisis. And we're showing that that's resolving crises in a way that doesn't require admission as much. So prior to where we were in 2019, we had outdoor replacements on a consistent basis. People had to be sent far away from their homes. Now we're able to accommodate everyone within the CNWL system for the beds. We've now got to the point where we're trying to move into a formal consultation on this changing clinical model the last 3 years. We have been working very closely with our ICB colleagues, and they're the ones who own this consultation and make the ultimate decision. The process that we've been working through is to have a pre-consultation business case, and we're doing a series of workshops with lots of partners. So we've had representatives from our local councils who are included in that. We've had service users, carers, and citizens from the communities involved. We've had partners from the police, from our acute hospitals, from the ambulance service, from our local work colleagues, and voluntary sector partners as well involved in those workshops. Through that series of workshops, we've gone through what is the overall clinical model we should be trying to follow, and some of that is around the balance of how much do you provide a model that involves adult acute inpatient beds versus community interventions. Then moved into thinking around what are the priorities around that clinical model, what are the options ahead of us, and they roughly break down into going back to where we were before, staying where we are now, or looking at a third alternative. And that's very much been in listening mode through those workshops around having the crisis assessment centre based down at South Westminster at the old Borden site. And we have then sort of whittled down that long list of potential options down to the short list of viable options. We have had another workshop just this morning with that group where we've looked at the equality impact of the potential options within that consultation. And we will be having another workshop next week where we look at data and finance and financial implications to triangulate all the different points of information that all our partners hold on this. All of that's been taken in front of the London Clinical Senate, which happened last week, which was a panel of 30 senior clinical peers that have scrutinised the model and the proposals put forward within that. They will be giving their feedback to us within the next 3 weeks. And then all of that is worked into the document that is given to the ICB, who then goes to NHS England to get the green light to go ahead for a consultation in September. So that is where we're up to with the process at this point. And if there's anything you want to add.
No, we continue obviously with our engagement with our staff, which also includes local authority staff. We have been meeting with patients who use our services and their families. It's also important to say that we have user representation and care representation in all of those workshops and within our sort of team as well, and it's been that ongoing conversation. And we have a further workshop coming up where we are working with partners around what that data looks like. We recognise obviously the urgent care pathway, which is really what we're talking about around people accessing support in crisis. Many people, many partners play an important part in that. So I think, as you said, Gareth, our acute trust, our local authorities, but also our police colleagues, and we have been seeking data from those colleagues. And we have an independent organisation called Real World Health that actually is working with all of the partners who submitted the information to bring that together. Because I know that's one of the questions that the committee had asked, really around what is the data telling you around your urgent care pathway. So in a couple of weeks' time, we are going to have an opportunity to do that presentation, and we really welcome people in the room to be part of that, further discussion.
Thank you. And thank you for providing us with this update. I really appreciate you running a few months ago, but this is an incredibly pressing and meeting that to this committee and our residents who are suffering from the closure of 51 beds. wanted to start by drawing your attention to the last paragraph of page 41, where you state that the data available suggests that patients are now receiving better care than under the old model. For example, patients are no longer needing to be placed out of area. My first question to you is, what is the evidence for better care and outcomes for patients, and how are they receiving better care? And then on top of this, what is your definition in this of out of area? In this case, is it outside of QC or is it outside of North West London? As they're very different definitions. And lastly, what have you learned directly from patients in terms of their feedback? As on page 46 in your workshop process, you list that you've been speaking to service users. And it'd be good to understand if these are past patients or patients who might have been cared for at the Gordon and now as a result of the closure and not being.
So in terms of how do we know what good looks like? I mean, certainly some of the alternatives that we've set up, particularly the mental health crisis assessment service, does give us that opportunity to work in the least restrictive option. And we have seen a large number of patients who've come in there, and only a small number of patients, less than 10% of patients, have needed to go on to have an inpatient admission. And those people who have had inpatient admissions from our health, they've had spent less time in hospital. And we all know that obviously when people spend less time in hospital, that is much better for them. And also trying to divert them in hospital is also positive. As I said in this meeting before, there'll always be times that people will need beds. I'm not going to deny that. We always need to ensure that we have beds available. But certainly having that range of alternatives certainly has been positive, both from that point of crisis, but also, as Gareth said, in terms of a step down, having that facility to ensure that people who are considered to be medically optimised, that means that actually from a medical perspective, from a clinical perspective, they are ready for discharge, but there are other aspects, holistic aspects, supporting people to remain well in the community, and having that opportunity to be in a step down bed where they continue to receive a more holistic all-round support is really important to build in that resilience and some recovery. So we've had really positive feedback around that. In terms of how do we define out of area, for us, obviously, out of area is outside the CNWL bed system. So we do recognise that there are patients from Westminster and Penzance and Chelsea who do go to other boroughs within the CNWL bed base. So we do acknowledge that. And just, I think your last question just.
So it's to do with the patient voices of who you've been speaking to. So who those patients are they people who could have been receiving care in the Gordon, or are they past patients?
We're speaking to a range of people, so we certainly are speaking to people who have had care in the Gordon previously. We certainly have one of our trust governors is somebody who has been a past patient, and so he's been supporting us. We've also got somebody who's working with us on a workshop who has been a past patient. We're also speaking to present patients as well who are currently using services now, and also their families.
Yeah,
because that's really important, because obviously, our people's families play a really important part in their care, and so this meeting was as well.
How did you have the patients come forward? Was everyone contacted?
We obviously contact as many people as it's an open invitation, and in fact we have used our health watch colleagues who set up the voice exchange, and through the voice exchange in that partner has contacted as many people on their list as they possibly can, and we certainly have openly invited people who are currently using our services to come and tell us their views.
And just before I move on to the rest of the committee, what's the narrative been from patients? You hearing one story, or has there been a very mixed?
There has been a mixed. I mean, obviously, some people who've been in the Gordon have had a positive experience. Other people haven't had such a positive experience. But what we're finding is that actually, as we're continuing on this journey, that difference is really important, and actually, giving us that opportunity, listening to think about how we can include everybody's views as we think about what that clinical model might be moving forward. And certainly, that has played a big part. Indeed, when we came to this committee last, we heard from this committee very clearly, please have better provision within South Westminster. We've certainly taken away that and thought about it, and that's one of our options and thinking of moving the MCAS to South Westminster, and actually thinking of us having an urgent care hub, because as I think we said at this committee before, there are services still within the Gordon, so the Gordon does have services that run from there around our urgent care, and so bringing that together. So patients, certainly patient feedback and other partner feedback has helped support us to think about that as an option.
Just a couple of things to add to that. The out of area placements definition is not ours, it's NHS England's. So that's what we have to work to, and what we measure on this. Where before the Gordon was closed, we had around 6 to 8 out of area placements every month. Based on those measurements, we had a really bumpy time through COVID, and there were times when that got very high for parts as we were trying to transition in these other new arrangements to help us with this. For the last 6 months now, we've eliminated it. So that's one of our data points for evidence that this is a better system than what we had before, was because we are no longer having to send anyone outside of the CWL system. Before, that could have been very far away. We're talking Norfolk, Western Supermare, Glasgow, but for where exterior placements might need to be obtained from. So we had problems when we were heavily reliant on a very big bed base, because we didn't have those alternatives in the community to de-escalate crises and to bring people out of hospitals sooner. So that's our piece of evidence around people receiving better care under the new arrangements.
If I could just add something, one of the pieces of work that we've done around our community teams is around our digital offer in terms of it's called Massive, around sort of managing supervision. Within that has an algorithm that actually picks up when people are becoming unwell, and that is supporting us, actually putting in a more proactive approach to actually support people in the community. It's really exciting, still very early days, but to actually have something that actually is starting to flag up when people may be becoming unwell is really welcomed. And that's what, as part of community transformation and the investment that we've been putting into community services. These are some of the things that we're beginning to see and that we're using as tools.
So, thank you, Chairman, and thank you for that. I have a few questions firstly about the engagement and the consultation. I'm just trying to really understand how these two things fit together. I mean, the themes seem sensible, what you might expect, and all of those, but how do you take that and then turn it into a consultation, and who's going to do that and what questions are going to be asked? But I wasn't at the last meeting, but I mean, I have to say, like, when I read this, it just all feels like it's designed to almost make it impossible for these beds to be reopened. We talk about, they're being refurbished and maybe they can never meet the historical standards, and the longer this all goes on, the less likely it is that it's going to open, because it's all, it's not getting better while it's all shut. So would you agree with that? If you don't agree with it, why wouldn't you agree with it? And how is the consultation? I think if you ask the right questions in the consultation, nobody will want it really shut down. So I'm just trying to understand the link between the two things.
So I guess the key things to answer around how is the consultation being designed is it is ultimately owned by the ICB, so it's the North West London ICS that only run the consultation. CNWL obviously the key partner in that, because we hold most of the information around, particularly the unit itself and the models of care that we're proposing to provide. So if we work in a really close partnership and providing information to them, they brought in an independent partner called Verve, who are running the consultation, pre-consultation process for us, and they are making sure that they facilitate all those workshops and gathering voices that are around those tables, make sure they're all included in the information that's being pulled together for that pre-consultation business case. It's a really good question about how do we set up a consultation to make sure we've got viable options on the table. There are some realities we have to face with some of the issues, particularly with the building, that it is a Victorian building that was built for surgery over 130 years ago. It's got limitations to it, physical size limitations in terms of what we would now expect to have on a modern mental health ward. you cannot get more than 13 bedrooms in that physical space if you want them to be en suite. We would say the standard you should always be working to now, planning ahead, is that you should always have en suite partners because for sexual safety, for dignity, for infection control. So that there's a reality we have to face at that particular building. It's got an old Victorian plumbing system. If we're actually looking for something that's going to be viable now for the next 10, 20, 30 years and beyond, that's all going to have to be taken away because it's been patched up enough times. It can't cope with another 10 bathrooms on every ward. You've got, so there are things like that become limitations as we start.
It feels like this is less complicated.
Well, it's really stark. They're difficult questions for the system to answer. Is that we have to face up to realities that it will need a large amount of capital and or potentially another site finding if we want to get really good modern inpatient facilities in that borough site as well. So we have gone through in that workshop process to look at what could all the feasible options be, and then they have to be run through the funnel of practicality.
Is there, I was going to say, is there another site you're considering?
So we have done an exhaustive site search of what's available to us now. We've gone out to all our partners, we've gone out to CLCH, we've gone to Imperial, and we've done our own estate search. We've not been able to find a viable alternative site.
I was just going to add, however, it is public consultation, and one of the options is to reopen and to refurbish. So it's really important for people to hear that. It is public consultation. There is an option, there has to be an option at reopening. If that is a decision that's made, then obviously the money that we have temporarily diverted into those services that we just talked about, that money would have to come. There would be a decision that would have to be made. It would be a collective decision. It would not just be CWL's decision, it would be a collective decision. And if that is a decision that's made, then obviously that money will go back in, and a lot more as well, to provide those inpatient services. But I just want to make that clear that there is an option, and obviously reopening that.
And it's just all about how you ask these things.
Yeah, I think that's true, but there will be an option on that consultation document that will clearly say the reopening of the beds. And because I want to make that clear that there will be that option. But I'd also want to make clear to colleagues that that is the decision, and obviously that will be a system, that'll be a decision that will just be our decision. Then we will be having to divert finances from community services into a bedded provision. And I just wanted to acknowledge that. That's
it's just a pure admin error on some of the report. You're talking about the previous Health Watch that's now called Listen to Act. So Health Watch hasn't had any current involvement with this.
That's correct.
But I just would love the contact of the person from Verve. Come speak with. I don't know how we can organise. I'm trying, unless there's a public consultation. Do you want us to be I can organise, because I'm part of the advocacy project as well, right?
Yes.
So we already have our service user group in there.
Yeah, that's right. Yeah.
So how do we ensure? Yes, absolutely. So this is what we need to decide.
We can link you in. Not a problem.
That's fine.
I'll get Sally to do that.
Okay.
And there was somebody from your service this morning that was with us. Yes.
Yeah, so it was just going back to Lucy's very first question about better care, because it is quite a bold statement. By better, do you mean least restrictive and keeping people out of hospital who don't need to be in hospital? So it doesn't really address the question of those people who do need to be in hospital. So because it's a very unusual definition of better care. It's just that patients are now receiving better care than under the old model. Least restriction isn't really relevant here, because those individuals wouldn't have needed inpatient beds.
So I'll pick up then.
Because I'm thinking about beds for people where it's clinically necessary, not where it's not necessary and they could have been diverted elsewhere.
So few different sort of aspects to that. The first, I do think the least restrictive bit is very important to the care, because actually people only need so much of a recovery in the inpatient environment. There's certain things we can offer within that, but then part of the recovery is being back into your community as much as possible, relinking with your family, those who love you, and that's where more recovery takes place than in the inpatient environment.
How long is the stay in the in those?
So the average length of stay has stayed the same throughout this.
Not admission, sorry, the average length of stay in the MCAS or the.
So I'm just going to start making notes of these.
Sorry,
there's quite a few questions.
In order to get people out of hospital safely back to their communities and back to their families, there does need to be a degree of discharge planning, and how much of that is, can be achieved in the assessment centre or the crisis house.
So where we were before, we came into this, roughly per month we were needing around 96 beds per month for the KCW population. Now where we are with our systematic is at the moment we need about 65 beds per month for the KCW population, so that we've reduced the requirement for the number of inpatient beds we're having each month, because we're successfully diverting at the point of a crisis into less restrictive options, such as being in a crisis house, which doesn't have locked doors and all the restrictions of the ward. It has people who are going to the MCAS who are given, we have far more time than we normally have in the emergency department. All the pressure of that space, we've got time where we can allow them to have a rest, have a sleep for a few hours. That's an intervention. We can call their family members, we can call the community services, get them involved. We can try and resolve that for them. And we're finding that previously that cohort, at least 30% of those were getting admitted into the hospital bed. Now we're down less than 10% into the MCAS, because actually it buys us that time to find those less restrictive solutions for people, working with them, keeping more at home. In terms of when we're providing the care in the inpatient environment, as I was saying before, now we need about 65 beds per month. For that, we've got an average length of stay of 32 days in these beds. So that's roughly a month, and we know that we've got 67 beds at St Charles. So we've got enough beds for the KCW population for what's needed at St Charles. St Charles is, I've worked up in Scotland, I've worked down in the southwest in Somerset, Bristol, I've worked across in North Central London for many years, and all the boroughs that were there. St Charles is the best inpatient environment I've come across all these different cities I've been to. If I had a relative, that's where I would be wanting them to be going. So in terms of the people in the inpatient across our two boroughs and the inpatient facilities that they can access, they are getting a better quality of care by being able to access beds at St Charles.
But so just on that point, the majority of patients who would have gone to the Gordon are going to St Charles.
Yes.
Which is, it's great that they're able to access this excellent facility, but that is a real concern for the people of Kensington. This is the hospital that them and their families go to in their own area. A huge proportion of something like 85% of the people who would have gone to the Gordon are now going to St Charles. And there is something about reducing the need. You've reduced the number of people who've needed to access beds each month by a third. And I mean, that's just, how can that be achieved without changing the criteria or the thresholds for admission? And there is nothing can, what's happening in the assessment centre or the crisis houses, there's just no way that can replicate having a full multidisciplinary team on a ward, nursing care 24 hours a day. You can't kind of discount how important that work is.
No, I absolutely don't, because that is a really important part of the care that we provide day in, day out. There is a time and a place where you absolutely need what an inpatient ward can provide. We're never getting away from that. However, it has its disadvantages. You have locked doors, you have alarms going off constantly around the ward. You have 18 people often in a very distressed state around you 24 hours a day.
Because we've raised the threshold so much for admissions, we're having more and more acutely unwell people on the wards.
You have to have nurses doing rounds, checking on patients every half an hour, opening doors, looking at you disturb sleep all the way through the night. These are really difficult environments to be in. So we really do whilst it is very important for the times when we need it, we absolutely need to keep it limited to the shortest period of time possible, and only for those who absolutely need those times. We know that we can provide better care in less restricted environments in places like crisis houses for those who are suited for it. We do very carefully screen who would be appropriate, and always do that in consultation with the person themselves and working out with them what would be the right fit for you and the needs at this moment.
And I just wanted to add that for many years now, we have been working with home treatment teams. They are intensive teams that work with people in their own home, and that they've been around for 10 years or so. They've been this whole move to actually support people better in the community so they don't have to come into the hospital. And I just wanted to add about the crisis house. The crisis house is supported by the home treatment team. So it's environment, but actually it has a wraparound from, so it's not like, you know, people go into a crisis house and they don't have any support. So the home treatment team will be visiting 2, 3 or 4 times a day. There is house staff as part of that offer.
It's a full MDT. It's exactly the same members of an MDT would have available to you on a ward. It's available to you be a ward level care in the community for you.
And I just also wanted to add that the MCAS actually has a higher staffing ratio than our inpatient wards. It really is a ward team, an enhanced ward team is how I would describe it, because recognising that need to really support people and to be there. So it's not something that is a downgrade from an inpatient service. It actually is a ward. The MCAS, in many ways, it actually functions as a ward. It's a 24/7. It actually has 24/7 medical support. And really has that intensity. It actually has more intensity.
What they have medics on site all the time?
Absolutely, at the MCAS, yes, we do.
That's not the on-call person, they have somebody that's there, okay.
Yes,
All
yeah,
right.
and that is the recognition that this is a service where people are coming in 24/7, which usually in a ward environment, you know, you will have some people who come in now, not that often, admissions are planned. But we want to try and reduce this long stays that people to wait to the ED, because people are having to wait still too long. I recognise that, I acknowledge that, and that's why we wanted something that actually had that access to a multidisciplinary team of people, of senior people who can, you know, make decisions there and then, and that's why it's a very enhanced service.
I mean, that's it really. My experience and the experience of people I know in the area is that they have loved ones who are waiting desperately for beds. Their clinicians in the community are saying they absolutely need a bed and there isn't a bed for them to go to, and they're left waiting for days, sometimes weeks, for a bed deteriorating in the community, which is why I was really struck by your figure of 6 hours, people waiting for 6 hours for a bed as the average or the longest, because the experience certainly in the community where I'm from is very different. People don't have that experience. So I mean, somebody else can
I've got something, but if anyone else wants to jump.
Can I just say, you know, I'm very happy, you know, there's an open invitation for people to come to any of our services, to come to the MCAS, to speak to people, you know, to come, you know, have that opportunity.
I visited the single point of access with Lucy and could see how overwhelmed the staff were there. Can I just ask one very quick question? The voice exchange engagement, has that elicited anything in terms of whether or not people want provisions for beds in Westminster? It's touched on very briefly, I think, in one of the themes.
I mean, what I've heard, and I sat into the feedback, was that people want compassionate, kind care to care as quickly as possible in that, and in an environment that best meets their needs. For some people, that will be inpatient beds. For other people, it will be the opportunity to have other offers. That's what I hear from people.
Yeah. But yeah, I mean, it sounds. The key things in the page 46, right in the middle of the page, messages were that it does include, you know, people want appropriate provision, including access to inpatient beds close to home and clinically appropriate.
Yeah.
Yeah. And I'm sorry, but close to home isn't Hillingdon. Out of area doesn't mean very much to residents. It's out of borough, or even the next borough or the one after that, not somewhere miles and miles and miles away. It's not right.
So this is just one of your earlier points, which we haven't had a chance to answer yet, that you were asking about proportions. So we know that there was always a proportion of KMC residents in the old system when it was open who had to be treated outside of KMC and had to go to the Hillingdon Hospital, to Park Royal, to Northbit Park, or sometimes out of area very far away. So that was always true. Since we've shifted into this new system, has that proportion changed? It has a little. So there's been a small amount of displacement of KMC residents out into some of the other boroughs of CWL. But the vast majority of people in KMC still continue to get their care in St Charles. We've got plans for how we can try and rebalance that and make sure that even more people from KMC than before Walden are getting treated at St Charles. And that would be to do with addressing the pressures of the outer boroughs, because what we've got the difficulty is we do have to operate across the system. It's normal in healthcare that you don't have predictable patterns of people turning up. So you might have 2 people from KMC at the emergency department one day and 22 the next day. And likewise with Brent, might be 22 the first day and 2 the next. So you never get a nice even pattern. So you've got the mutual aid across the system allows us to respond quickly and safely, because that's our #1 priority. When somebody really does need to be in patient aid, you need to get them in quickly and make sure, and by having extra capacity across the system and flexibility of shared capacity across that, we can move people in quickly and then try and bring them back locally as fast as possible.
I'm just going to ask one too. Just in terms of the refurbishment, and I know you don't think it's maybe possible in the way that you envision the care. Is that because of money? Because it's a huge building. Surely that building could be redeveloped to a standard that could be used for intubation beds, even if you had to go to whoever's in charge of that lot of money and say, we can't lose these beds. This needs to be operating, and there's such a huge demand for these inpatient beds. I just think in terms of going into the consultation, the language you've used on just this report saying, which I know you're just being honest with what you've got in some respects, the Gordon can never meet the desirable standards. No one's going to have hope in that option if you're using that language. So why can't we kind of be having these pre-conversations saying, we're coming to these committees, we're speaking to residents, and we're speaking in engagement consultation, and these are the demands of St Charles. There is this inpatient centre that is needed. This building can be redeveloped, but we're going to need a bigger budget, because surely it's possible. I know it's Victorian, but there's lots of Victorian buildings around here and people live in them.
So a couple of points to come on that. One is the physical square footage of one of the ward spaces, which I was pointing out to you before. So if we tried to go up to minimum safe standards, that would cost us around £3 to £5 million on capital to get that work done, to get it up to just minimum safe standards, and not getting it up to any of the care we would expect to see going in for the next decade. So that would be the basic. And we would continue with 4 bathrooms for 18 patients, and all the restrictions on airflow and the problems with ligature points and windows and everything that we have at the moment with that site. So that wouldn't be a viable. So we would end up paying £5 million. So around £3 to £5 million into something that will be non-viable beyond 5 years. Mm-hmm. So that's sort of like a crude sort of appraisal of trying to get them just open at a minimum level. If we do want to plough in the full 13 million that would take to get it up to the desirable longer term standards, we're still left with a space that could only at the maximum get 13 bedrooms into. Now, there's a minimum staffing complement you need for running a ward. You need to have a consultant psychiatrist, you need to have a ward manager, you need to have a psychologist, you need the sort of minimum staffs that you need to run on these. And it's no longer economically efficient if you run it below 16 beds. That's a sort of given across the NHS. It's less than 16 beds is not an economically viable model for us in terms of the cost per bed, and we're funded for from central government to run one of these. So you've got big capital constraints. You've then got the revenue constraints of this. So it takes running those wards and the wards around 4.5 million for just the running costs of it, for paying the staff and the running the costs of the building. And we've moved that revenue to providing these alternatives to the community, the step down beds, the crisis house, the mental health crisis assessment centre. We believe that providing better alternative care. We would have to shut those off to provide we can't provide both. We don't have the revenue streams for both options.
And also the challenge important is the outdoor space.
Yeah.
We just don't have access to any outdoor space.
So the only outdoor space that is available is this caged roof garden on the top of the building. And you would have to, well, when we have the 3 wards, they have to have this rota system where people couldn't immediately walk out to get some fresh air if they needed to blow off steam, be away from other people, whatever it may be. You had to go and ask permission, wait to be escorted up there, had to check out whether other wards were using it at the time. It was very limiting. And you've got to bear in mind, whilst we try to keep people in for 32 days as an average, and try to do that as short as possible, some people are very unwell and need long periods of time for recovering these spaces. They can be there up to a year at a time. And can you imagine being in a space where you were restricted against your will and not having ready access to actual space for a whole year?
So where will those people go now? They'll go to.
So they're going to St Charles predominantly now.
All I'm going to say is I think in terms of the consultation and the budget around that, I think there needs to be a positive case.
It will be very careful. It will be very carefully presented.
I think we'll take our feedback. Absolutely.
It needs to be not phrased like that, because I hear everything you're saying, but
yes, no,
some beds is better than no beds.
Yes.
And I know that you believe that too.
Yes, yeah,
that means there's more community work alongside of it and step down beds, that's great. But I think you need to have a positive approach to, even if that means begging someone for some more money because it is so crucial that they do exist, then I think that's what you should be doing.
And regeneration not being sort of coupled with closure of other resources.
Yeah, exactly. I mean, I've got a seriously tough job in that respect, so
unfortunately,
but I think it losing other services, exactly what Min is saying, should be the cost of any of it. But that, yeah, I really strongly suggest.
And there are people in here far more expert at this than I, but when I read this, it does read a done deal.
Yeah.
Maybe it is. And maybe the done deal is better than what there is now, but it doesn't come across that it's really being looked at.
I do think that comes across in all your papers. It feels like the decision has already been made, which I know you're not necessarily trying to do, but sort of within the background of it, I think that's what we will see. So, any further questions? Or
Just what are the next steps? What are we going to what happens next? The US consultation in September. That's going to take 3-4 months.
Yes, that's
Early next year.
So yes, sort of towards the end of this calendar year, into the early next year, the ICB and want to ultimately take a decision in conjunction with NHS.
So what weight does the London Clinical Senate have? That sounds a very grand body.
They certainly hold the clinical case to account, and so they're scrutinising all the plans. They give back a lot of feedback that has to go into the pre-consultation.
They're not decision
makers, but they do advise into the ICB. They do advise into NHS England and provide their full report into both of them for them to be able to do the case being put forward as well. Seem to be well.
They are a powerful voice. They really are. They are testing. Does the clinical model stack up, basically?
I'm going to move to Sarah.
Thank you, Chair. As Carol Sarah said at the beginning, I do feel that the beds that we suspended as a technicality, they've been shut for over 3 years. By the time we consulted, it's going to be almost 4 years. So the decision has basically been determined. At the last meeting, we talked about data and data sharing. That hasn't happened. The agreement hasn't been made for whatever reason. And I know that it's going to be a workshop to work through those pieces. So I think, we agreed at the last meeting here and one of the workshops, data is so important. It's key. We don't know, we have one set of data which says we need beds. And your data, you're telling us every time that there's no need for extra beds. On the point about the state, I know there's a lot of underutilised or empty estate, NHS estate. There must be somewhere where you can find 15 beds, not at all, somewhere in Westminster. I really, it's so important those beds are there while you consult.
So just a couple of things. Thank you very much, Councillor Group. The data is really tricky. It really is. We shared data pack with you as part of the workshop which is the data we've managed to get together on our side. We have done an appeal out to all the partners who've been in that workshop to bring their data in on this. It's a really complicated bit of the pathway. You've got so many partners in that. We've got the mental health services, we've got the acute hospitals, we've got the police partners, the London Ambulance, and we've got the social services and the AMP teams, and they all have different bits of this jigsaw. And we've tried to go out to partners across London, nationally, to look at who measures this pathway well, can we benchmark against what you do. Nobody does it well. Nobody has really been holding this bit of the pathway properly to account and scrutinising it in a really clear way. No one's been bringing those data sets together in an organised way on a regular basis. There's no KPI set nationally on this. So it's a messy bit of the business. We have put that appeal out to partners. We're going to have that workshop next week. We've had a limited response. We've had very limited data put into us for that workshop. So if anyone else has stuff that they've still got to submit to that, we'd really love to see it, because we do want to triangulate and try and bring it together. The point around there, could we open 15 beds somewhere in Westminster? It's really tricky around how do we keep up safety and quality with an isolated unit. So once you've got to a full acute adult inpatient ward, there are certain needs of patients who are admitted to sites like that, where you do need to have enough collaboration across units to keep it safe. There are times when staffing levels might drop. It might be that 3 members of staff with norovirus and fallen sick. You need to be able to move staff quickly as the shift changes to keep the staffing members safe. There's times when we have to do physical interventions, so we might actually have to go and restrain somebody, de-escalate them, and you need to get a number of staff members together for a team to safely intervene. And you need to take them from all the units across the sites to assemble, because you can need up to 8 members of staff to do that kind of intervention safely. And by having that, you need that codependency. Having a site on its own doesn't allow you to have those scales of numbers to do it safely.
Just one thing on the consultation. I know previously been talked about, proposed that one of the things could be reducing the number of beds at St Charles. Just want to go on record, that's not acceptable to Kensington and Chelsea.
Thank you very much for coming. The subcommittee, after discussing the issue on the 2nd of May and again tonight, we need to consider the recommendations that I know we've had circulated. Can I check with you, as the committee are happy to agree these recommendations to CMWR? Ensures that the pre-consultation business case includes the option of refurbishment and investment at Gordon Hospital, so that modernised inpatient services can be reopened, which meet high quality standards of care for patients. So that's a positive refurbishment case that's put forward, not necessarily in language that we see. Ensures the pre-consultation business case reviews the implications of rising demand for mental health services in RBKC. What inpatient services will be needed to help meet the mental health needs of RBKC residents, particularly in the context of the Grenfell tragedy, and commits to commissioning additional acute mental health inpatient provision for RBKC residents as required, and urgently reviews any pressure on services at St Charles Hospital and wider mental health services in RBKC, which have resulted since the temporary closure of the Gordon hospital wards. We'll send these to you, but is everyone happy and agree with it? And is it quick?
Yeah, I think I was just going back to the question about the data, just basic things such as detention rates or lengths of admission, sort of pre and post the closure, and like failed discharge rates, that sort of thing, pre and post would be really helpful. And following on just from the last meeting, there was also a request around liaising with ICB colleagues about what additional services might be available for when the tower comes down, if there was anything to feedback about that.
And additionally, just to refresh on what we spoke about today, getting Danny and Health Watch more involved in the workshop, which I'm sure you do, and I think a visit for the committee to MCAS. But thank you very much for having me. Moving on to agenda items 7, Director of Scene Setting. The report provides members of the Adult Social Care and Health Select Committee any information about the Adult Social Care and Health Directorate. Lead member of Adult Social Care and Health presents with Minister Patel, Director of Adult Social Care and Government Aspirations. Thank you very much.
I'll start this while we're all settling down. Thank you very much, Chair. Thank you for having us. So this is a team setting report that provides an overview of the different parts of the Adult Social Care and Health Directorate. The report outlines the structure under which the teams operate. Some of these are sovereign, some of the elements of the service are by borough, and some of the service elements are by borough. The report also outlines the statutory framework under which support and services are provided. Approximately 1,500 RBKC residents are supported with an adult social care service, and 80% of these services are provided in the community. These are services like home care, direct payments, day opportunities, and then we have approximately 20% of residents who are supported in either extra care, supported living, residential, or nursing provision. 63% of adult social care users are over 65 years old, so obviously the service has quite a large client base in terms of old people, and annually the service supports over 1,000 carers in terms of supporting them with their care and responsibility, signposting, information and advice, and providing carers direct payments as well. The report goes on to describe the departmental functions in more detail, and then it also talks about the risks and priorities at the end. The net budget for the department is 38.5 million, a gross budget of 72 million, and the annual public health grant is 22.9 million, 22-23. So you'll see that there's quite a big gap in terms of net and gross budget, and the department is very confident that it will deliver a balanced budget, but there is a lot of income that comes from one-off grants to the department at the moment. So we are seeing pressures in our services, we are experiencing financial pressures, and central government is sort of in recognition of this provides things like discharge grants and one-off funding for adult social care in the kind of impasse that we are at in terms of adult social care reform and those being delayed. But these are one-off grants. We have no certainty about how long we're going to receive these grants for, and we're notified of these on a kind of annual basis. So there is definitely some work to do in terms of our long-term funding for the department, and there will have to be some reassessments of MTFS and budgets for adult social care. So we're happy to invite any questions or any points of clarification from the committee.
Thank you so much for running us through this. My only question was on the finance and funding section of the report. You just asked if you could speak more about the funding reforms that are coming into effect and how these might impact the portfolio over the next year. Page 52. Thank you.
So we talked about the budget. There was supposed to be a reform of adult social care services. This was delayed in the autumn, and it will be delayed until 2025. So there were 3 areas that were going to be looked at. One was about the introduction of a lifetime cap in terms of the contributions that people make towards the cost of their care. Another area was the fair cost of care and determining the cost of local provision in terms of stabilising the care market. And there was another around changing the upper capital limits. I think the reality around adult social care reform is that there was a white paper that was released which had very limited detail in it. So although there were commitments that were made as part of that white paper, there was no clarity around how those commitments were going to be funded and how any money would then be locally provided in order for adult social care departments to meet those financial commitments. I think the word probably to use is unclear. We are unclear about what the future funding model and position for adult social care is, and obviously that is a risk to the department.
If I may, Chair, thank you. So no, that's absolutely right, as Manisha said. Sorry, I probably should introduce myself properly. Bernie Flaherty, so the Exec Director of Adult Social Care and Health. So that's right in terms of the reforms, but you know what I guess I need to reassure the committee and ourselves actually is that although the reforms aren't there, we're not waiting for reforms to come in. Our job here as officers supporting our residents is to make sure that we have all the funding that we need to get, that we're expected to get. It's mainly from health, but not just from health, so that we get as much as that in and we have our base there. We need to make sure our markets are as strong as we can get them. So that's about partnership working. It's making sure we pay the correct wage. It's making sure we look at a whole variety of areas there. And it's actually making sure that our quality measures, and how do we measure quality? Through our indicators, of which we have many, to make sure that we are assessing on time and reviewing, but also remember we have a framework. I think we may have had it at previous scrutinies, we certainly will be going forward on what our residents are telling us from their reviews. What are the kind of things? Are we empowering our residents to be able to tell us what their needs are rather than the more traditional model? So they are all the things that we do. In addition to that, the part of the reform that is coming in is the inspection assurance regime, which will be in by September, October. That gives us another measure to ensure that we are carrying out the right outcomes and services for our residents.
Any other questions?
Thank you. Very good, useful explanation for someone like me who's new to this area. So thank you for that. I think I haven't seen something so well set out in any of these committees for what the Directorate is doing in scene setting. Just a very basic question first from me, 2.1. Net and gross budget. Obviously, different departments may have different definitions, so it's not checked. Your definition.
So it doesn't include things like income and, so that's what the growth budget includes, absolutely everything, and net is
controllable.
Yeah, we can control.
Just help me a bit on that. So net budget is the amount that you are spending or the amount you are receiving.
The gross budget is what it actually costs us, but we get half of our income. Half of what it costs us we get in our income, not just from residents, we get it from, it's probably the health services is the majority. But some of it is from residents.
Okay, so starting at the top, the figure 72 million is what you'll spend doing what's in the scope, right? Okay, so that's what you've got to spend.
Yes.
You're getting a grant of 22.9 from public health.
That's a separate budget.
So On top of the gross.
That's right, in our directorate, and it is complex.
Yeah.
We've got the adult social care, which is 72, but also under our directorate is also 22.9 million.
Okay, so you're spending 85.
As a department, yeah.
As a department,
Okay.
yes.
That's-
Very different functions though, but you're right, as a
Okay.
department, yes.
And so the adult social care spend out of that is 38.5 or 72? Okay, so what's the 38.5?
It means that that's net of income that is received. There's a bit more to it than that. We have charging as well.
Yeah.
We charge our residents. We have income from the Better Care Fund. We have etc., which then gives you a net budget of 38.5
Which we have to find.
that we find from the
That's
charity.
brilliant, but
It costs one thing, but the bit that we have to find is the 38, the bit that we're funded.
Just reading through my next sort of topic, and this bit you sent me some information which I don't have on the device here, and I didn't print out, so you might have to remind me. But I just wanted to understand the profile of residents receiving services, and the figure that I first saw was over 1,540, and then I was looking just at the ward layout, just to understand how diverse or demanding the borough residents' needs are. And I think I saw, just from memory, and you might have it in front of you, I said, what are the numbers per ward? There were some very good stats, and some of the services being provided in some wards were because it was below 10 people.
Yes.
And maybe one or two, you can't actually give that information to protect people, etc. But was there a figure, and again, it's just what I saw on the paper that's in my head, was there a figure for I can't remember the exact number, but for people who weren't RBKC but were receiving services?
So
Emily might have it in front.
There's an out of borough.
Out of borough, yes. So what was the number for out of borough?
For overall, 326.
Okay, so thank you for that. So my question was, does that mean, because I was looking at ward profile, that out of the 15 to 40 residents supported, 326 are not RGKC?
no, it doesn't mean that.
Okay.
It means that the service that they're being provided, most likely a residential or nursing service, is not provided in borough, and they are out of borough.
They are
an RBKC resident.
Okay, so that's the confusing bit. So, for example,
Yeah.
does that mean on the chart that we've got 11, where it says, I know, for example, Colville 103, just to take that one as an example, that means there are 103 Colville residents receiving care in Colville. So there will also be an additional number of Colville, for example, residents who are receiving care out of borough.
Yes, in a residential or nursing placement.
Okay, right. So 326, we don't have a sort of ward breakdown
Of the out of borough.
of those there. Because once they're out of borough, they're at what point do they stop being considered as in borough? If you're sort of spending 10 or 20 years somewhere else.
So there's no time limit. It's about responsibility. So if our residents who are just living outside of the borough, they're still our residents for the length of time they need our support services. If they were to move out of areas, get a new location, new residence, new accommodation address, then they'd be deemed a new ordinary residence in a new borough. But for the time we're supporting them, they're our residents, they're ours.
Right, it's interesting, because I know one case of someone who moved from a London borough to Wolverhampton, and the borough said that's us finished with it. It's now Wolverhampton's case, and so calls relating to this person from Wolverhampton saying you need to go do that. But that person is out of borough or still part of.
If they make a choice to move, so they move home, they move to another borough, they are now no longer resident here. If we place somebody, so someone who is resident here says, I have a need, we assess that need, but the only home we can find, or perhaps they want to be near their family, is in Wolverhampton, and we place them in Wolverhampton, they remain they remain our responsibility.
Because they didn't head off there by choice.
Yeah,
Because
we
of
based there,
steps,
they're
yeah.
our responsibility, and we retain that for as long as.
That's all, thank you. Going to write this one. I got very excited at 9.2, because this is my sort of thing. And I thought you're producing this really excellent performance analysis, data management, and working with products to improve data management. I was wondering, and this may be to the chairman here, more view. Is there something which you think would be helpful that is a short 1 or 2 page summary that would actually say a lot of the things that are going on a regular basis, so we are half the year that we can see? Because sometimes, sometimes what you see in a report of 25 pages can be in a 2 page piece of data that you're already producing for your departments.
So yes, we can provide a performance summary perhaps on a quarterly basis. We already talked about providing something. That would be great.
And I'm saying for my purposes, don't make something brand new that requires extra work. Is there something that's produced already that you could easily just manufacture through? I always want to make sure don't reinvent them or something that might be useful as well.
Okay, absolutely.
Chairs, just going to say on that, we can absolutely do that. There's a whole variety that we enjoy capturing. If you go through, there's certainly some summary ones, which I think would be really important. The only point to note is one of my points earlier was around CQC and the new assurance framework, that it may change. Mm-hmm. But certainly for now, we would probably be able to choose the top 5 or 6 quite easily. We'll be able to do that for next time, no problem.
Yeah, I'm really conscious of the time, so you don't need to answer this right now. If you could just direct me to where I can find information about how the commissioning decisions are made as to how we access and pay for specific services in terms of so standards are used and sort of how we quality assure that and quality assure how the carers are, paid and treated.
Definitely, that's the one director who's not here, but we will make sure that he'll have that information.
Gerard.
Yeah, it really is the purpose of the paper in a way. So a lot of information in here. So I have 2 areas of just some clarification and then some questions about the content. Para 3.2. The first bullet point there, highest life expectancy for women, the second highest for men in England. Para 3.3 is a statistic that we've been familiar with. That sounds a bit, we've got the highest the discrepancy as well between. Can you just explain a bit behind that? Do you understand it?
Yeah, so one of the challenges that we have in Kensington and Chelsea is that we have very affluent populations living alongside very deprived populations. What you then sometimes see is those affluent populations moving ahead with substantially greater life expectancy than some of our more deprived populations, and that creates that sort of larger life expectancy gap you're seeing.
And is that getting larger, or is it?
So what we have seen recently, and some of it links into COVID, I think more of it will link into cost of living crisis potentially, is that we have seen nationally an increase in the life expectancy gap, and we're seeing that moving through local as well.
Okay, thank you.
So one of our challenges around inequalities is to look to reduce that.
Yes, yeah. So if we stick with Para 3.3, bullet point on the next page, emotional well-being. 1 in 4 adults report feeling anxious, which is a statistic. Is that, where's the benchmark for that? Or as a borough, is that higher than the national average, lower than, how big an issue is it for us in relation, any statistic is bad, how big an issue is it in relation to other boroughs?
Okay, so what we have tended to see as well post-pandemic and now the advent of cost of living crisis is significant increases in anxiety and depression amongst our population. So there are some groups that we are seeing variation in across our patch, so particularly children and young people. We're quite concerned about at the moment. But some of that data is emerging and coming through, and we're looking to understand that better, particularly in terms of our children and young people. We're monitoring very closely our data on suicides at the moment. Today, we haven't seen an increase in suicides locally, but there are a number of indicators that we are monitoring and looking to see those impacts on. In terms of looking for a comparison across London boroughs, that's something I can provide you with.
Health Watch has it. I can email it if you want.
Don't compete, it's all right.
Well, then recreate the way. We've already got a whole game we can share over, and then it's all our info. Yeah, we're in the middle, I think. Thinking back, but yeah.
Thank you.
No problem.
Okay. Sorry, am I hogging the?
I mean, I do think we should move on to the last item, so we've got a bit more than usual, but if it's a quick one.
Okay, maybe for the future. So again, para 10. I know a lot of this from now on priorities. And maybe this paper is only to give the priorities, but it doesn't tell us what's going to happen about them. So if you look at that first 10.1, working across council, strength and direct working we have. What are we going to see? What are we going to see? And then further down, 11.1, third bullet point, care market fragility and inflation. Yes, we've known that for 20 years. We've tried our own Chelsea Care. What's going to happen differently than we've done before?
Yeah.
You don't answer that now, but at some stage it'd be useful to take this paper one stage further and say, that's great. Now what's new or different?
There might be on agenda as well.
Yeah.
That's right.
Good point.
Yes, we've got plans in, hopefully in the autumn, to bring a more detailed paper in collaboration with partners across the council to share some of the whole council approach to public health to reducing inequalities, which will look at some of those specifics I mentioned in terms of.
Thank you very much, and thank you all for waiting so long. That was paper. Moving on to agenda 8, work programme report. This report is an update of the work programme scrutiny setting out the reports received in the municipal year and responses to requests for information. Select committee members are recommended to confirm their strategic priorities to I'm still about to say my word. Yeah, as set out in Appendix 1, note the actions in Appendix 2, which were completed in the last municipal year. Yeah, great. That seems great. There are no urgent items, as everyone seems to say. This concludes this meeting. Oh, sorry, this
I've got one urgent item. Going back to mental health.
Yeah.
Next Thursday, we're going to do an event at Arlington at 6 o'clock. It's inviting the community to come and talk. And I will send you something. We've just been really agreed today, so I will send you something. But yeah.
Thank you. That's thank you. This concludes this meeting of the committee. Thank you everyone for your time attending. Thank you.